starting with Chapter 14, Care of the Family After Birth. The first hour after birth is so important. Most hospitals have a one-on-one nurse-to-patient ratio for the entire hour. If the mother had a C-section, the patient is often on a heart monitor also. L&D nurses had to go to class to learn how to read the EKGs in the room to be able to respond quickly if something was happening. Remember, immediate postpartum care involves checking the fundus. It should be midline and at the umbilicus. It should feel hard like a baseball. The bladder must empty completely or it can displace the fundus. Gentle palpation if a C-section. Both hands must be used to not cause inversion of the uterus. If atony is present, massage is required to prevent hemorrhage. The lochia is the name of the discharge that mom starts having right after delivery. You can see the terms here, rubra, serosa, and alba. It should always go in that order. Rubra is for usually about up to 3 days. Serosa is day 3 to 10-ish. And then alba is up till about 21 days. It should go in that order. It shouldn't go backwards. If mom has already had serosa for 2 days and all of a sudden she's got the dark red blood again, then she needs to call the doctor. Something's wrong. She might be being too active. She could have an infection or something else. She should not be saturating a pad an hour. That would be too much blood. Remember, 500 mils for a vaginal delivery, 1,000 mils for a C-section is the typical blood loss. Mom needs help getting out of bed at least the first couple of times. She can have that orthostatic hypotension, so we need to be careful. She just had a huge shift in water, right? She's lost a lot. So we need to watch her. She typically has vital signs Q15 for the first hour and fundus checks Q15, and we're going to make a note of the bleeding. Bubble LE is the acronym that will help you remember the focused postpartum assessment. Mom's breasts by about day 3 or 4 will become engorged, especially if she's not nursing, but they're going to be engorged even if she is nursing. If she's not going to breastfeed, she should wear a tight bra, no stimulation, take her pain meds. If she's nursing, we can provide comfort. She can still take her pain meds. We can do cool packs in between feedings. Cabbage leaves in the bra actually provide comfort. She should not pump in between feedings to relieve the engorgement. The body works on a supply and demand, so if she's pumping, her body's just going to keep making more. It will adjust as baby eats and gets into a pattern. Warm packs can help with letdown, and cool packs can be used in between for comfort. Remember, the bladder needs to be empty to avoid uterine atony. We may need to get an order for a straight cath if mom cannot void. Bowels may be slow after delivery. Colace is often prescribed so mom does not have to strain. Remember REEDA, R-E-E-D-A, redness, edema, ecchymosis, drainage, and approximation for checking that episiotomy or laceration. We do ice for 24 hours, and then a sitz bath is so nice for healing after that. Remember, ice reduces swelling. Warmth will promote healing. We are checking mom's legs for any early signs of a DVT. So we're checking Homan's sign. We are asking mom to flex her foot so her toes go towards her knee. We're feeling for any swelling, warmth, redness, or pain. We're asking mom if she has pain when she does that. C-section women are going to have the sequential devices applied right in the delivery room, and they need to leave them on anytime they're in bed. Early ambulation is so important. Moms go through a lot of emotion. Those hormones are really fluctuating, so they can be happy one minute and crying the next. We need to just be careful that mom is not experiencing anything worse than the baby blues. If she had a previous psych diagnosis, we would definitely want to teach her signs and symptoms of depression and psychosis. Even though a mom had a C-section, she may have pushed for a while, so her perineum may still be tender and swollen. Holding a pillow on her abdomen helps when ambulating. It takes the pressure off of the incision. Also, when we teach her to cough, holding a pillow can help also. SCDs and early ambulation. Infection is usually not identifiable by her labs. The white blood count is usually high in moms after delivery, so we would want to teach other signs and symptoms of infection. We're going to do RETA. We're going to promote the incentive spirometer. We're going to remove mom's catheter. We're going to assist with pain management and assist with breastfeeding. The football hold may be an easier way for mom to nurse after a C-section. She may need to talk about that C-section over and over. She may ask 5 different nurses what happened. It's not that she doesn't believe you, it's that she just wants to understand, because quite often it can be an emergency and things aren't explained real well to her. We have to be very careful with our language. We never want to use the word failure, failure to progress, failure of the baby to descend. We want to make sure that we're not making mom feel worse about the situation. For our teen moms, we need to encourage them to make decisions for the baby. She may be used to her mom or her dad or whoever her caregiver is making decisions for her, so we need to encourage her to do it. And her mom may be there trying to take over because that's what she does, right? But this new mom has to make decisions about immunizations, naming the baby, completing the paperwork, choosing the pediatrician, having a car seat, having things ready, knowing how she's going to have the baby cared for if she's returning to school or her job or whatever she's doing. So we need to really encourage her to take charge. Some women come to the hospital with their adoption all figured out. They have chosen a family. They're turning the baby over to the family. The family may even be present during the delivery and in the room afterwards. Some moms are turning the baby over to an adoptive agency and they want nothing to do with it. They don't even want to see the baby. In this case, we can move moms to another floor of the hospital so they're not hearing babies and seeing babies and wondering if that was their baby. Usually the transfer of the child takes place out in the parking lot. Hospital personnel must hand the baby over to whoever is legally on the paperwork in charge. But even if mom doesn't want to see her baby or have anything to do with the child, she still needs to complete all the paperwork, the birth certificate and anything else. The agency handling the adoption is usually who the baby will be discharged to. This can be very emotional. Moms can change their mind at the last minute. Let's see. And she may be grieving. Even if this is their choice, it may not be what she truly wants, but what she knows is best for the baby. So be watching for that grieving process also. Here's a question and here's an answer. Complications. Postpartum hemorrhage is the #1 cause of moms dying after giving birth, and uterine atony is the #1 cause of postpartum hemorrhage. When there is no contraction of the uterus, the vessels that were supplying blood to the placenta remain open, causing a rapid blood loss. What are the risk factors? Did she have a prolonged period of Pitocin? Was she induced and in labor for a long time? Was her uterus overstretched due to a large baby or twins or triplets? Is the uterus fatigued due to the prolonged labor? Late postpartum hemorrhage can be due to subinvolution. So mom can even have a postpartum hemorrhage after she goes home. We need to teach her about this stuff. Early recognition saves lives. Never leave the patient. Massage the fundus. Give drugs as prescribed by the doctor. See page 206, table 4.1. We're going to be weighing pads. We're going to be maybe inserting the Foley catheter if she doesn't have one. We're going to be giving her IV fluids. Elevate the legs. Her uterus may need to be packed. She may need dilation and cauterization. We may need to get a type and cross, O-neg, if not available, if it's an emergency, right? This picture shows a balloon that can be inserted into the uterus to apply pressure to all the walls of the uterus in a case of a postpartum hemorrhage that hasn't been controlled by anything else. If mom says that she's having pain in the vaginal vault or the perineal area and it is not being touched by her pain medicine, we need to think hematoma. A hematoma can be filling up with blood, putting pressure on the area, mom's perineal area. She might not be able to go to the bathroom if it gets big enough. She might be showing signs and symptoms of hypovolemic shock because that hematoma is filling up with blood. If we find one, we need to get the doctor in there right away, or we need to call the doctor to see if they can find it. It can be near the vagina. It can be near the vulvar area. Did they have to use forceps? Did they have to use a kiwi or a vacuum on the baby? All of these things can increase the risk for a hematoma. Endometritis. The risks are on page 209. E. coli, GBS, signs and symptoms. What are we going to get before we do the antibiotics? We need to have a culture, CBC, an ultrasound to detect retained placenta. Does she have an abscess? These are all the things we're going to be thinking about for infection. Remember Rita, fever, CBC, culture, then antibiotics. UTI signs and symptoms. We're going to get a urine specimen. We might need a culture and sensitivity. Then probably antibiotics. Teach proper cleansing front to back. No wiping. Pat dry. Catheter, prolonged catheter use can increase the risk of a UTI. Mastitis is infection in the breast. Cracked nipples are an increased risk factor because we just created an opening, right? Staph aureus is the most common bug that causes this. Mom's hands, baby's mouth, a red, warm area on the breast. Usually it's swollen and hard. Mom will run a fever. Mom can get chills. She can get an abscess, a sore on the outside of the breast, but not always. She can continue to breastfeed if she doesn't have the abscess, and we really want her to at least pump and dump her milk if she doesn't want to feed it. The infection is usually not in the milk duct, so the milk is safe. We need to teach, again, proper hand washing. Usually mastitis is unilateral, meaning it's only in one breast, so she can continue to nurse on the other side. The thromboembolic disease, remember, we had those increased blood clotting factors so that when the placenta pulls away from the uterus, we don't bleed to death. So mom's got some increased fibrin, which can lead to a setup for a DVT or a PE. Signs and symptoms. Are we going to massage this? No. We're going to assess for Homans. Remember, look for a lump. Tell the doc they may order a Doppler ultrasound. If they find a DVT, mom will probably be put on anticoagulants for 6 weeks or longer. What are the precautions for anticoagulants? Page 211 might help out with this. What kind of labs might we draw? Question, answer.